Recording in progress.
Hello, everybody. Welcome back to The Broken Brain. It's Dwight here with you. I'm your host for today's little trip around the intersection of psychology and culture, and as we like to focus on, healing and health. One of my greatest messages that I like to push out there is that when we get into psychological and mental health, unfortunately, sometimes we still like to talk about that as if it is different. We'll say, is that mental health? Is it medical health? Is it what? They're the same. Mental health is medical health. And my guest is going to help us to talk about that much more today. Joined today by Susan Trachman. She's a medical doctor who's an expert in treating medically unexplained illnesses through the lens of psychiatry. She's been practicing for over 30 years, and she is also the author of a new book. It's Not Just in Your Head, Demystifying the Brain-Body Connection in Medical Illness. So, Dr. Trachman, thank you for being here.
Thank you so much for having me.
I was so excited to read the areas of focus and your bio there because I'm just a big proponent of this. I push it every time I hear people say, like, well, is this medical or is it mental? And it's like, no. That's not a difference that we need to make. So I'm excited to hear about it. Could you tell everybody a little bit about yourself and how you got into this kind of focus in your work?
Sure. Well, I when I went to medical school, I had lots of different ideas about what area I thought I might want to specialize in. The problem is I was interested in too many things, which is often the case with me. And then I was lucky enough to do an elective with a physician as a third-year medical student, who I referred to in my book as Dr. Kent, in quotes. But we'll refer to him here as Dr. Kent because it's a funny story. So Dr. Kent was British, and he was actually trained in neurology and psychiatry. And he was quite the character. This was back in the late 80s, and he wore his hair long. He had a bushy mustache. His favorite dress was clogs on his feet, and he would take his white coat and he'd kind of pop the collar up, so he kind of looked like, I guess in those days, a cool guy. And so he liked to think of himself as, a version of Mick Jagger.
Nice.
And the interesting thing is, he had lots of followers, and the male psychiatry residents who were on service liked to emulate him. So they too would let their hair grow a bit, and they'd pop their collars
All of a
up.
sudden,
Anyway,
the pop collars started coming out. This is great. I love this.
So to make a long story short, Dr. Kent, he was tough. He was intimidating, and but he was to his credit, he was a great teacher. And one of his favorite things to do, when we would usually make rounds in the hospital, he would point to one of us, sort of pathetic third-year medical students, and he'd point to us and he'd go, "Diagnosis." Meaning he would be pointing, there'd be someone walking down the hall, a patient, and he'd point to one of us and he'd go, "Diagnosis." Well, one time I was lucky enough to have looked up the symptoms of Parkinson's the night before. And as we were walking along in one of the medicine floors, he looked at me and he said, "Trachman, diagnosis." And I looked at him and I was like, I see this older gentleman shuffling down the hall. And I'm like, "It's Parkinson's." And he looked at me and he goes, "Are you asking me or telling me?" Anyway, so he was sort of scowled that I got it right. So why am I telling you the story?
Somewhere you got it wrong.
No, so why am I telling you the story? I'm telling you the story because the part of psychiatry, the specialty of psychiatry that he worked in those days it's called psychosomatic medicine. Excuse my voice, I have allergies, but psychosomatic medicine are real medical conditions that are mediated by what's going on in your brain, right? And that's, in some ways, why is it the title of my book? It's not all in your head. Because it's not. Your brain's connected to everything.
Right.
So we learned a lot about medicine. We had to know a lot about neurology. And I found that, wow, these are three areas of medicine that I really like. I like psychiatry. I like neurology. And I like medicine. And maybe this is an area that I could possibly pursue. Well, funny story, and then I'll get off my funny stories.
I feel like
at the end of this rotation, we're called to see this lovely woman of Greek heritage in the intensive care unit. And she's in the intensive care unit because she had successful open heart surgery. She was doing fine, but the team that was managing her in the hospital couldn't understand why they couldn't regulate her blood sugar. She was on, a diabetes diet, and they made sure that they knew what they were giving her, and they managed her medication. They couldn't get her blood sugar down. And they noticed that her blood sugar would be particularly high after a visit with her family. So they called us in, as I called us the psychiatry SWAT team, come in and figure out what the problem is. So a bunch of us go down there. We talk to this lovely woman. She's delightful. She understands that she has diabetes. She understands that she has to sort of manage this because it's a component of why she had heart disease. We asked her about her family. She's very close to her family. I said, did you ever get sort of anxious, when your family comes to visit? Because sometimes if you're under stress, your blood sugar will go up. I'm like, nope, happy to see my family, love my family. So then we decided to do a physical exam. And yes, we're psychiatrists, but we're medical doctors and we do physical exams, right? So we do a brief physical exam, lungs, and we're going to listen to her heart. This woman was slightly overweight, and so she was fairly, shall we say, busty. And in order to listen to her heart, we actually literally had to lift up her breasts because we couldn't really get to the area we needed to get to. And there we found our answer. It wasn't because she wasn't on a diabetic diet. It wasn't because she was anxious or concerned about seeing her family. It's because she was hoarding Twinkies under her breasts.
Wow.
And so to this day, we think of her as the Twinkie lady. Her family were bringing her snack foods. And so Dr. Kent, who never did anything but scowl, laughed so hard that I think the nurses heard him down at the nurses' station. And back to your original question, why did I go into this field? I went into this field because it's fascinating. And again, even when you think you know the answer to something, it's very likely that you don't, and you may be surprised. So that's how I came full circle to this.
Yes. No, I love that. That's a great example of that, because when you run through things, it's like, well, it's this, or this, right? And I think that sometimes in clinical field, in the medical field, we're sort of trained to say, if you think it's this, you're going to find out you were correct, or that it's the other thing you thought it was, or something like that, right? And then to say, are you really then actually intending and following through with actually observing, asking, listening, doing all the things that you would do if you actually didn't think that you knew what the problem was.
Right. And I think and I'm often asked this question about, why is it that I can figure out some of these issues when other doctors can't? And it's not that I'm smarter than them. I know I'm not. I mean, I like to think I'm good at what I do, but I'm not smarter than them. The reason is that medicine has become a business, that many practices have been purchased by hospital systems or venture capital groups. And once that happens, it's all about the money. Right. So a provider within a group like that has to make certain numbers in order to get a bump in their salary or a bonus. And so let me ask you, Dwight, here's a question, and I don't mean to put you on the spot, but let's see how well you do. What do you think the average amount of time is for your typical primary care visit in this country?
I bet it's lower than I'm going to say. I mean, right. my gut is 15 minutes, but I bet it's 7.
No, you're very good. You're very, very good. It's between 15 and 18 minutes.
Really? Wow.
Yeah. And think about it. If you're a patient who may be a little bit anxious about going to see a provider anyway, and you've got these symptoms that you know are real, but you want to go in there and describe these symptoms to your provider in a logical manner, but you've only got X amount of minutes, it's very challenging. And for the provider who's got to come up with some type of a diagnosis and treatment plan, they're going to try to get to the core of the matter. And which is why it often, for folks who do have these symptoms that don't fall easily into one category, they get passed along to providers, different specialists. They'll send them to a cardiologist. And again, well-meaning cardiologist is going to try to find something they can fix in their heart. And if they can't, well, it's not in your heart, maybe it's in your lungs. So they'll pass them off to a pulmonologist, a lung specialist. And again, this is not to be malicious. This is because they're trying to be helpful. And I think most of us went to medical school to try to do good, but we've become so specialized and so siloed in medicine that if things don't come easily or don't match up consistently with a physical exam or laboratory studies, it's going to be like, we can't find anything wrong with you. It may be all in your head. Go see a psychiatrist. So that's how they end up in my office. Mm-hmm. And when they do, my response to that is, well, that's true because your brain is in your head and your brain is your central computer and it's connected to all of your organs.
Right.
So whatever's going on in your brain is going to send messages to all of your peripheral organs, and then they're going to respond. And that's why we see some of these disorders that are, quote, and I put it in quotes, medically unexplained. They are explained. You just need to know where to look.
Yeah, that's that phrase, and I love how you said that because that's something I've thought for a long time. Is if something's in your head, it's like, well, everything's in your head. I mean, technically, without the organ in my head, I'm not alive. But even aside from that, everything's being interpreted, both internal and external stimulus being interpreted by your brain. But of course, people walk away from that statement. And unfortunately, the way it's used also is not that way, is to say like, oh, that means I'm crazy or I'm making it up. That's what we take from a lot of times in a medical interaction. If the doctor is like, well, maybe this is all in your head, then the message I think people get is that there's something wrong with you and I can't waste my time on you because I have real patients to see or whatever. I feel like people interpret it that way.
Well, I think, I've asked this to groups of people when I've given talks in person. And I was like, how many people in this room have been told there's nothing wrong with you? Go see a psychiatrist. And inevitably people raise their hands. And I say, and how does that make you feel? And it's often, I feel dismissed. I feel demeaned. I feel as though they're not taking me seriously. I question my own competence. Like maybe I really don't have something going on with me. Maybe there really is something else. And it's not a pleasant experience at all for the patient.
It's also not a great endorsement of the field of psychiatry or psychological treatment if it's like, nothing's wrong with you, now go see this person. It's like saying, this is where you go when you really don't have anything wrong with you. You're just so broken that you think there is. And it doesn't really treat psychiatry as medicine very well either, if that's the attitude, if that's the statement, right? There's just not.
For a long time, as you said, I think we were talking briefly before we started recording that for a long time, and maybe some people still do think of mental health and physical health as being separate entities. But what I'm fond of saying to people is, if I cut your head off, could you function? Of course not, right? Everything's connected. And, over the course of the history of medicine, and we're talking like centuries back to the times of Hippocrates.
Thank goodness that we don't do that anymore.
Yeah, absolutely.
Yeah. No,
anyway. The thinking about this has changed. And, sometimes theories have gone into favor and sometimes they've gone out of favor. And, Hippocrates actually was a big believer in the connection between the mind and the body. And he believed that all was caused by the four what he called humor, and kinds of gross thoughts. But
sure.
and then when we started to find that microorganisms actually cause certain illnesses, I'm thinking particularly about polio, and unfortunately they developed vaccines against polio. The trend in medicine was then to think of one germ, one illness, and not consider anything else. And it wasn't really until the 1960s when a doctor named George Engel, started working at the University of Rochester, that the whole view of medical illness is what we call a biopsychosocial model, and became popular. So there's obviously the biological component, your genes, the psychological component, whatever your mind's, your mood state, is, or your brain's and social, sociological. Think about the Twinkie lady. I mean, we didn't think about, well, what's it like when your family comes to visit? Oh, they bring you Twinkies? Okay, well, you know what I mean? So
sure. There's a whole social kind of like they weren't doing it because they hated her, right?
No, they loved
her. She wasn't eating them because she wanted to die, but it was a pattern, right? It was a behavioral, social, cultural kind of a community, whatever the values are that are tied up in that. So absolutely, to the factor that plays in our behavior, which then impacts our health, right?
Right. And then looking at illness from that perspective, again, I think I write about this, quite a bit in the different sections of the book, is it's not just medicine that we use to treat you. We look obviously at psychological components, but also at behavior. What's your diet like? What's your sleep like? Mm-hmm. What's your social interaction like? How much do you exercise? I mean, these are things that perhaps some people don't recognize as being major components in a lot of chronic illness. Mm-hmm. Heart disease, the American Heart Association cites stress, psychological stress, as an independent risk factor for heart disease. So it's not just psychiatrists who are looking at it from this kind of lens.
Mm-hmm. It's always interesting to me as well, speaking as someone who's worked in addiction for a lot of my career, you get a pretty firsthand understanding that there is an emotional, psychological component to those behavioral choices that in many cases will sort of transcend the traditional medical feedback. And in other words, if someone says, hey, if you do this again, you might die, even once, you'd think, mm-hmm. Our natural logical assumption is, well, I won't do that thing. But that's not how we act. Most, many of it. There might be a few. There's some people out there that are like, oh, I behaved this way too much, or I had too much of this or something, and it scared me, and I course corrected. There are people that do that. But majority of people, it's like without some type of like the psychological and emotional underpinnings of why I do what I do are powerful enough that I might still do that thing here and there, even though it might kill me. And so the overlap of that area, I think, is one that when you have maybe a medical appointment and they just say, oh, stop eating this or it's going to be bad. All right, see you later. Come back for a checkup, I guess, whenever, whatever. That's maybe not much has happened that's going to change anything.
Well, I think, one thing to recognize as that systems like to resist change. So an individual is a system, families are systems, even in nature. Think about a pond. You've got this sort of equilibrium of species living in the pond, and you throw in a new species, and everything that's living in the pond has to learn to adapt, right? Or die. But systems generally resist change, and the term for that is called homeostasis. So if you tell someone, like you just said, you go see a doctor and like someone's got a medical condition, the doctor says, well, you need to lose weight. How do you think how do you think the response is internally is, hell no, I'm not doing that. However,
especially the response is, it's, oh, that's the first time anyone's ever told me that. If I have,
of course, right?
Yeah, right.
So, but there's also, I think, a negative connotation when someone says to you, you need to lose weight, rather than something like, we know the data really shows that in order to improve your situation, following something like the Mediterranean diet can be helpful. Mm-hmm. So that's not putting someone on a diet. It's giving them some options of the kind of food groups that will be helpful to them in improving their medical outcome, rather than saying, yeah, I think the unspoken term, you're bad, you're fat, you need to lose weight.
Right.
Right. So who's not going to resist that?
Mm-hmm. Yeah, especially when that ties in. And I think they've found, a lot of people anecdotally have found, and I think there's been research that if someone is above a certain weight, particularly women, tend to hear that from medical professionals without them doing further testing sometimes to find out if that's really the issue. So, there is a lot of reasons why people don't always listen to that too, where it's like, oh, you walked in the room and saw me. You gave me the same feedback the last 5 doctors I've talked to and all of my family and friends have given me for years, and I don't really believe that you actually even care about what's really wrong with me. Even if that is something that is necessary, right? There's so much complication that goes into that. that is kind of bred from that managed healthcare model you mentioned, of just feeling like even if I am being given good advice, I might not necessarily have a lot of faith that the doctor is really paying attention to me. Yeah.
Or that they really have enough time to listen and figure out what's wrong with me rather than just zeroing in on one thing when I'm telling you I have all these other things going on.
Right. What kinds of things do you find are helpful in when you're working with a patient to, obviously there's multiple things you're trying to overcome here, which is getting to real information. I'm sure there's testing. Obviously there has to be some kind of a relationship rapport, just all those things. What do you find are some of the obstacles to overcome?
Well, in some ways, I feel like I have the luxury that other specialists don't have. And number one is time. I never schedule less than an hour for a new patient. I am not purchased by venture capital or a hospital. I work for myself. I was taught very well in medical school. One of my attending doctors in particular, he was actually a MD and a JD. He was a lawyer and a doctor. He went to med school after he had gone to law school. And I remember him saying to me, Dr. Trachman, the best thing that you can do is listen to the patient because they'll tell you what's wrong. And you know what? He was right. I mean, they're not going to give me a diagnosis, but if you listen to someone and you get more of a holistic view of what's their life like family history, what are your genetics, psychological, do you have any history of, depression, anxiety, repetitive thinking, substance abuse? What's your family situation like? Do you have a family? Where are you from? What was it like growing up? What was your education like? What's your work life like? I mean, all of these things come into play when you're trying to arrive at a diagnosis. Like I said, I have the luxury of, number one, having that kind of training, but number two, having the time to listen to it.
Do you find that there's, of course, the sort of old school resistance, the kind of, I'll talk, you listen, guru, expert kind of thing back then. And then I also noticed these days there's also a potentially combative element where people do research on the internet. And on the one hand, many professionals find that to be a waste of time or annoying or whatever. And then also many people feel that they need to do that because they're not getting enough information maybe from their doctor. So I'm curious about how you see that relationship there of people hunting their own information.
Yeah. Okay. So let me sort of answer that if I can in two different ways. I have heard patients tell me that when they're in situations where they feel dismissed by a provider, one of the things the provider says is, stop listening to Dr. Google. So being dismissive of their attempts to understand what's going on with them. I think we should be well-educated providers of healthcare, but I think you also have to be careful at what you're looking for. So I wouldn't be looking at Reddit sites. I wouldn't be looking at sites where people are just calling to complain about certain medications. I would look at verifiable sites such as Mayo Clinic, Cleveland Clinic, Johns Hopkins, what's the other one I'm thinking about? Mayo Clinic, Cleveland, Harvard Health. They have wonderful resources for learning about symptoms and diagnoses. I think those are totally well worth one's time. And the other thing I wanted to talk about briefly, because they actually connect, is something called medical gaslighting. So I think we're familiar with the term of gaslighting in general. Medical gaslighting is kind of what we're talking about, is when you go to a provider and you're telling them what's going on with you. And because things are not showing up diagnostically easily on a physical exam or lab studies or radiographs, the sense that you're made to feel as though there's something wrong with you that is not something that they need to be figuring out. So it's as if they're not assuming any responsibility for it, and it's more on you, like, what's wrong with you? We can't find anything wrong with you, right? The other thing that I'd like to talk about with respect to that is the whole idea of gender bias in medicine, meaning the data really supports the fact that women are treated differently than men. in terms of the way they're treated by medical providers. So if a woman goes to the emergency room with severe abdominal pain, chances are she's going to be told she's constipated and get sent home with a laxative. If a male reports to the emergency room with severe abdominal pain, he's going to have a workup, including a CAT scan, to make sure he doesn't have a burst appendix. And that, again, is just a form of medical gaslighting. Women present differently than men. Women who are having a heart attack don't always have chest pain. They may present with what looks like indigestion. We're built differently, right? I mean, we have things the same as you guys, but we're built differently, and a lot of us present differently. So if you're not the right age or the right sex and you don't fall into the right category, you may not be considered for a diagnosis that falls into that category, even though you may very well have it. So
yeah, it's something that, and I'm amazed how many people really either don't realize that or don't want to realize that, I guess. I feel like a lot of internet outrage these days is people pretending they don't know how to read or understand things. But there's plenty, as you put it, there is plenty of data as well as people's own shared experiences to show that it's like, oh, especially when those things result in death or further injury, when you send someone home who is having a rupturing appendix, for example, right? Because you didn't bother to look for it,
Yeah, and I think, I'm fond of saying to my patients or to others, you know your body better than any doctor does. And you know when there's something wrong. And if you're being told there's nothing wrong, you are fine and well within your rights to not go back to that doctor. Find someone else. Do your homework. I'd like to say you wouldn't hire a plumber without checking their references, right? So if you're not pleased with the experience that you've had with a medical provider, you don't have to go back. You're paying our salary. We work for you. And there are very reputable sites where you can check physicians' references, patients' experiences with them, things like WebMD, health grades. These are verifiable sites, which are not just, like Reddit posts saying, oh, this guy's a jerk, I'd never go back again. Right. No, they really do.
No, I like the concept you're talking about, sort of when it comes, because people are going to do research anyway. That's, we have so much information available, but to then, as you're putting, kind of educate around, yeah, good, look for things. By the way, here's some places you should look for things.
Yeah.
And Reddit is a great place to look up maybe why my garbage disposal isn't working. And there's a bunch of people who post on that, and I can easily, verify that. But to say, why does it hurt here? Maybe not the best.
Right.
But considering that source, but also to me, it sounds like a big part of this, whether it's listening or educating or the way that you make these recommendations, a big part of it is communicating respect, so people feel respected.
Yeah. One of the other areas of psychiatry that I practice is called forensic psychiatry, which it's not dead people. I work with the legal institutions. Like, I'll do evaluations for attorneys with respect to things like, employment issues, traumatic injuries. And oftentimes when folks come into my office and I'm working for the attorneys that are on the other side of the case, I'll flat out say to people, I want you to understand that even though I'm not working for the attorneys on your side, I have been paid already. My decision and my opinion is not based upon, and my pay is not dependent upon what I say today. I always ask to be paid up front before I even look at your records. And if nothing else, I want you to walk out of this office feeling as though you've been respected. So, and if you're not, then I really want you to let me know. So, I think we owe that to folks who are coming to see us, right? It's a privilege in my opinion, it is a privilege. I know that's not shared by other people, by some other people. I still think it's a privilege to be a physician, and I've been practicing for over 30 years. And sure, we get burned out. But the truth is, people are coming to us in a very vulnerable state, and they're paying us money. So I think at the very least, we deserve their respect, even if we don't come up with the exact diagnosis. At least the respect of saying, I've heard you. I've looked at all the data. I'm really sorry. I cannot come up with a solution, but here's somebody who might. And I've done that where I'm like, I don't know what the answer is, but here's somebody who might.
And I think that the willingness to be open in that way, typically it's funny because it goes back to simple communication. If in interpersonal communication, honest vulnerability leads to trust. But yet when we have a position of authority or a position of expertise, we feel pressured to say, oh, I should be able to fix everything. And so I just assume that it's within my scope, right? And that I will fix this. And I definitely can't tell you if I'm not sure. It's definitely embarrassing if you see me looking up stuff or whatever. No, but, to be able to communicate that to people. I'm curious about, I always like to get good medical, feedback on some things we get to know, and then they break into, they go viral, concepts get out there or whatever. And I noticed that you write about like the gut brain connection and things. And I feel like that is a good example of something that everybody seems to know about it, but to actually get the medical perspective of what is the connection between gut health and the brain. And I wonder if you could share a little bit about that.
Oh, sure. I'd be happy to. So the first thing to know is that the brain and the gut are actually derived from the same embryonic material. So before you were even a fetus, before you were just a bunch of balls of cells, some of those cells migrated north to become your brain and spinal cord, and some of them migrated south and started to live within your gut. And that second brain is called the enteric nervous system. So one of the reviewers for my book is actually my gastroenterologist, who I see every 5 years just for preventative, scope. But she and I talk a lot about this because I see lots of patients from gastroenterologists. So the fact that the gut and the brain are derived from the same material, think of them as like besties who are texting all the time because they're connected through a many hormones and structures, but the big structure that connects your brain and your gut is called the vagus nerve. That's also become very trendy, and people are doing all kinds of off-label things with
this is
vagus
why I like
nerves.
to talk about it from a real medical perspective. Because
vagus nerves, and I think one of the best sellers on Amazon is like something about your vagus nerve, and it's written by a Rolfing healer, which has nothing to do with medicine.
Right.
But so when your brain is anxious, it's going to send a message to your gut, the enteric nervous system, your second brain, and it's going to say, we're anxious. And what the brain does in return is it responds. The brain responds as if we're under attack. So what's it going to do? It's going to put out more acid, which is why people end up getting reflux. It's going to cause an increase in digestion, which is why some people get diarrhea when they're anxious. Or it can do the opposite. It can cause, constipation, because through this whole mechanism of, we're anxious, it changes the neurochemistry of what's going on, which causes some of the symptoms that we're describing. It's really not uncommon for me to get someone referred for a diagnosis of irritable bowel. And to me, irritable bowel is just untreated anxiety. Mm-hmm. And so if you treat the underlying anxiety, the IBS symptoms go away, or they certainly get better.
Yeah.
But the other thing that happens if your brain is anxious and your gut is anxious, if your brain is anxious, it might not eat the healthiest diet. So you've heard about stress eating. Well, typically when people are stress eating, they're not eating like, carrots and low-fat yogurt and grilled chicken. They're snacking on salty, processed, packaged foods. And that has implications as well, because in your gut live healthy bacteria and not so healthy bacteria. And that's normal. But what you want to do is maintain a healthy balance. When you start eating a whole bunch of junk food because you're anxious or you don't have time, or like I remember the days when it was, final exams and I wasn't even going to the cafeteria. I was eating out of the whatchamacallit, the snack machine. you can get an overgrowth of the bad bacteria. And when that happens, it can cause inflammation. And inflammation is bad for us, no matter where it comes from, whether it comes from stress, whether it comes from injury, whether it comes from infection. Inflammation is bad for us because it causes bad things to happen in our bodies. And that's in some ways why you manage what's going on in your brain. You can manage sometimes the symptoms that are going on in your gut and vice versa.
And you'd have it's interesting how you mentioned that the brain eats. I like how you said that, because it's like a lot of times that's simply the technique, once again, to get someone to change that is shame, right? Of like, well, you can't eat that way. What's wrong with you? Instead of being like, you're probably seeking that out for a reason. And you point out, I mean, obviously there's the salt and sugar and all those kinds of things, but sometimes it's simply the ease, because if I'm anxious, I'm probably also exhausted because I might not be sleeping well, and I'm just under stress and tense all the time. And I don't maybe take the time to even chop up veggies and make little snack bags for the week, or little healthy something, or actually cook something, because I'm too exhausted to think about that. And so this stuff, junk food, is ready to go as soon as I open the package.
Right.
Yeah. That's interesting. Yeah. And yeah, it is. And so as you're describing that, when you're looking at the underlying and anxiety seems to have such a high role in all these things. And I really appreciate what you said there about IBS, because my experience with everybody I've known, really, I think everybody I've known who has been diagnosed with IBS has said that they felt like they were sent away with that the diagnosis was also the complete knowledge that they were given. In other words, if you're told you have irritable bowel syndrome, it's like, well, what does that mean? Your bowels are irritable, and it happens often. We're going to call it a syndrome, and that's really all we know about it is the name.
No,
and that seems to be what people walk away from when they're told that, is they don't. Well, what do I do? Right?
Yeah. Well, yeah. There's lots of things that you can do.
Right.
Even besides changing your diet. I mean, there's a well-known gastroenterologist at the Cleveland Clinic, and I think I used her quote once, and what she said was, if you can only do one thing to improve your gut health, exercise. Mm-hmm. Because exercise also improves your gut health. Yeah. As it does lots of things.
And then that gets into, once again, the untreated elements of the anxiety or other, those kinds of things they have to be addressed to do that. I wanted to ask too about, you write about the link directly between depression and heart disease and the way that those work together too. I was curious if you could say a little about that.
Sure. So, again, as I said, the American Heart Association lists psychological stress as an independent risk factor for heart disease. But if you're depressed, again, your brain is sending signals to your heart, and it's not so good. And oftentimes when people are depressed, they're also anxious. And we know that anxiety leads to elevated blood pressure, again, an independent risk factor for heart disease. But this is one way that depression affects the heart. I'll give you some dramatic examples. So I can't recall the date, but I think people generally know who Carrie Fisher was. So Carrie Fisher of Star Wars fame was about 60 years old when she was coming back on an airplane from, I can't recall where, and developed chest pain. Her mother, Debbie Reynolds, who was then alive, was expecting her for Christmas dinner. And sadly, Carrie Fisher died of heart disease. She didn't survive. And 3 days later, her mother died. Mm-hmm. Now, Debbie Reynolds didn't have any pre-existing heart disease. Same thing happened with other folks who are fairly well known. I think people generally know who Johnny Cash is. His wife, June Carter Cash, died. I can't recall of what illness in particular. And Johnny had underlying illness. He had, diabetes. He had other heart medical illness. But again, he didn't have any underlying heart disease that we knew of. And shortly after June passed away, so did he. So what do we call this? In common terms, it's called the broken heart syndrome. But it's something real. It's not just a made up thing, broken heart. And The official name for something like that is called takasubos. That's a Japanese term. And in Japanese, it means octopus pot. And the reason it does is if you look at someone who's survived but is experienced takasubos, you look at their what's called an angiogram. It's an image of what their heart looks like during that time. It looks very similar to the shape of an octopus pot.
Wow.
And what it does is it causes damage to the big pumping part of your heart called the left ventricle. The good news is if it's caught, it's reversible. So one does not have to die of this. But clearly, the impact of being a tremendous loss and depression takes a toll on other organs, and one of them is the heart.
Yeah. This is something that it's always been kind of a pet peeve of mine when I hear, like, people will present at the ER thinking they're having a heart attack and it's an anxiety attack, or people will have which is what you're describing, where it's like, oh, you're having these symptoms, but it's and here's the phrase, there's this part I hate, where it's like, oh, it's just anxiety, it's just depression, so go get that taken care of. And to me, it's like, if I'm at that level, why is not every medical professional I interact with really worried about me and saying, instead of being like, oh, once again, the tone is, oh yeah, we checked you've wasted our time, so now go talk to a therapist, weirdo. I mean, that's what people, once again, they walk away with that message. It's not intended, I don't think. But then it's fascinating you're saying, it sounds like, so the broken heart, what's it called? How did you say the octopus pot in Japanese?
It's called takats. I'll spell it for you. It's TAKOT SUBOS, Takatsubos. It's like a spelling bee question.
Yes.
I think the national spelling bee, I think, is this week.
Everybody bookmark that word. That's word of the day. But it sounds like can have a very, very quick onset, though. So, I mean, is that something
it's a
you should
onset.
It sounds like it's something to almost be proactively looking for when someone's going through, we say grief and loss is just like, oh, give you a hug and bring you a casserole. But how much should we be watching for things like that? Because it sounds like it can drop a person pretty quick.
We should be looking for it. But again, in modern medicine, with time constraints, and you're going to look at the most likely candidate, that may not be number one on your differential diagnosis.
I guess it's a well-worn path here to say, but not a lot of medical approach is proactive or looking for things before they go wrong, I guess, unfortunately.
I like to think the best medicine is probably preventative medicine, because it's much easier to prevent something than to have to fix it.
Right.
It's just like the car. You try to sort of do checkups for your car so that you're not going to be faced with, like a dead engine. Mm-hmm. It's the same kind of thing with our bodies. We're not built to last forever. Right. And if we take care of ourselves and do our own preventative medicine, again, like eating a healthy diet, getting enough sleep, exercising, limiting alcohol, having social contacts, we're going to do ourselves a lot of good. But it's still important to have a checkup, preventative medicine, so that you maybe even catch something before it becomes more significant.
Yeah. Do you have any guidance for people when they are going, let's say the majority of people who are just having that experience of the hopefully 18 minutes per checkup or whatever, what kinds of things can they walk in there with, either mindset or tools, or what should they look for to see if they're having, because frankly, most of us aren't going to get more than the 15 to 18 minutes. That is our doctor experience. How can we make sure we're getting the best we can?
That's a great question. I'm glad you asked it. So what I recommend are several things. Number one, if you can, bring a trusted family member or friend with you as a second pair of eyes and ears. A lot of people get anxious going to a doctor's office. We're still thought of as, authority figures. Some of us wear white coats. We've got fancy diplomas on the wall. And it can be intimidating for some folks. Number two, write down your questions. It's hard to remember things when you're anxious and you're feeling like your doc is pressed for time. Mm-hmm. Do your homework. Like I said, we talked a little bit earlier about what kind of research can you do. Check out different sites, but make sure they're legitimate sites. And again, things like Mayo Clinic, Cleveland Clinic, Harvard Health, these are legitimate places, even the National Institute of Health, where you can sort of even plug in your symptoms and you may actually come up with some ideas, so that when your doctor says we don't find anything, you can say, well, have you thought about this? Do you think there's maybe other tests that we could run that would be helpful? Or is it think that there's someone else that maybe I should see, like a specialist who you think can help us come up with something that perhaps is not showing up yet? You're less likely to feel like, you're like flapping in the wind when they're not giving you an answer that you need or want.
And people get nervous to do that, but I know people personally who have either themselves or their loved ones' lives have been saved by bringing in some well-found information and saying, hey, can we
Absolutely.
look at this? And,
Yes.
To the point where it's literally like, wow, even when they have a really, like, they've been really working and their doctors are great, and they're like, hey, I read this from this source, and the doctor said, oh my God, well, let's run this test. And it turned out it was really, really helpful, So.
Right. Yeah, when I have patients who say to me, I've read an article about this that you might be interested in, I was like, great, send it to me. Just send it. I'd like to be better informed too. I mean, you don't stop learning when you graduate from medical school or your residency. I mean, I'd like to think that we continue to learn throughout our lifetime. Otherwise, what are we?
I know in my field, in my corner of the medical world over here with therapists and psychologists, they've done studies that show that a shocking or alarmingly high number learn very little after about 5 years in practice, something like that. As far as new techniques and new things that they do or research that they either participate in, or because the majority don't, they'll be like, I got my skill set and I'm not really doing much else with it and 5 years is not the average length of career that you hope for. So therefore, learning and continuing learning is super important, obviously. Well, this is a very, very useful stuff. I think that medical stuff is such a big part of our lives anyway, but particularly when we're dealing with access to care and trying to make the best use of the time, I think these are some really great tools to be aware of. And I really appreciate specifically the unifying of the medical model with things that should be included in the medical model, but are not always considered that way when it comes to mental health. I think it's really, really important. I want people to know where the best place for them to locate, to get the book and to follow your work. I always like to ask people when we can, if they would be willing to share something with the listeners, something that they care about. It could be a charity or a nonprofit or some way of kind of, giving back to the community that you might like to suggest to people out there.
Sure. Well, I think, and I've changed, where I send my charitable donations. I mean, I do multiple, but, when the war in Ukraine broke out, I was supporting, World Central Kitchen because they were providing hot meals. And then when the economy in this country really took a dive, I've started to support more local food banks and organizations that, feed those who are homeless or in shelters. And then finally, one of the loves of my life are animals. And so I do support the local shelters, animal shelters. I used to support the American Humane Society, but I wasn't really sure that all the money was going towards animals rather than, some of their advertising. And there's actually, if I can just plug one more, sadly, one of my own pets passed away 2 years ago at the age of 16. And two of my friends also had elderly dogs that passed away within the same time frame. And I found a wonderful organization called Gray Muzzle, which basically supports elderly pets that are in shelters or perhaps will not be adoptable and need, medical care. So that's a new charity that has been on my list of support. I think it's a wonderful idea.
That's cool. I had not heard of that one before.
I hadn't either until I did my own homework.
Huh. I like that. I'm with you too. I think that finding local, not that there's obviously some national and international charities that they have a lot of outreach and all those things, but as far as the bucks get into the things that they need to, I find that's why I like to promote local charities when we get a chance. Especially on here, the monthly focus we have on charities and stuff here on the podcast. I always look for local because there does seem to be that real kind of boots on the ground interacting with the people or the cause they're helping. So I really appreciate that. Thank you. Well, where can people follow you or your work rather, not you personally? And what is there a better place or lesser good place to find the book?
Sure. I mean, I think probably the easiest place to find the book. You can certainly go to Barnes and Noble. either online or in person. But I think for people shopping around, the easiest thing is to go on Amazon. If you go on Amazon Books and just type in the title, it'll pop up. And they ship it pretty quickly. And it's also available now as an Audible. If you want to find me, I have a website. It's www.susanbtrachmanmd.com. And I also have an Instagram where my wonderful social media guru posts episodes that are sometimes excerpts from the book, but there's certainly topics like we're talking about, like mind-body medicine topics and references, so that you can look for more information on this topic in that place.
It's wonderful. Thank you. Thank you for sharing that. And once again, the book is It's Not Just in Your Head, Demystifying the Brain-Body Connection in Medical Illness, which came out in April of this year. And so, thank you for sharing it. And thank you for putting that together. I mean, I know it's not, books don't write themselves. And I appreciate the work of the creative and expert people who come on the show all the time. So I thank you for making the book for us as well. So,
well, it was my pleasure. I hope it's helpful.